I want you to just imagine getting a paper cut.
Okay. Ouch, but sure.
Right. Now imagine placing that paper cut on a hinge, like a hinge that is constantly moving, constantly stretching, and is being repeatedly exposed to salt water and acid.
Yeah, that is, I mean, that's a visceral image.
It's horrifying, right? But that is exactly what you brought to us today, because you sent in this whole stack of research centered around a really specific, honestly slightly intimidating medical phrase, which is fissure at the posterior commissure in the context of lichen sclerosus.
It does sound incredibly dense on paper, doesn't it? I mean,
Yeah.
it prioritizes precision over accessibility, which, is useful for a clinical chart, but it completely obscures the intensely painful chronic human experience happening underneath.
Right, just sounds like Latin.
Exactly.
Yeah.
And understanding this requires translating that clinical distance into, well, a real understanding of both the local anatomy and the systemic immune system.
Okay, let's unpack this. Because thanks for sending us down this rabbit hole, by the way. Our mission for today's deep dive is really to translate this dense jargon into a clear, fascinating story.
I love that.
Yeah, we're looking at exactly what a fissure at the posterior commissure is, and how doctors manage it when it's driven by lichen sclerosus. But before we even touch on the disease itself, we have to understand the geography of the body we're talking about. The where and the what.
Right. So we are looking at the female external genitalia, specifically the posterior boundary of the pudendum.
Pudendum is just the broader term.
Yeah, it's just the collective medical term for the external reproductive organs,
Yeah.
the vulva. So if you picture the labia majora, which are the outer hair-bearing lips, they extend downward and backward.
Okay, tracking with you.
And at the very back, toward the perineum, they don't just join together in a sharp seam, like a perfectly sewn edge.
Right.
Instead, they appear to become lost in the neighboring skin, like they end close to and nearly parallel with each other.
So they sort of taper off and just blend into the surrounding tissue.
Exactly. And that specific meeting point, the band of skin connecting them at the base of the vaginal opening, is the posterior commissure. Or it's also known in the literature as the posterior labial commissure.
Got it. So it's essentially the bottom hinge of the vaginal opening, like the floor of the doorway, so to speak.
Yes, and mechanically, it is a foundational piece of tissue. I
Yeah.
mean, it experiences a massive amount of dynamic movement and stretching on a regular basis.
Which brings us to the second word in our big intimidating phrase, right? Fissure. Now, in geology, a fissure is a massive crack in the earth.
Right, like a ravine.
Yeah. But in dermatology, I'm assuming it's just on a micro scale, like a small crack or a split in the skin.
That's right. It's a linear tear. It breaks right through the epidermis.
Which is the top layer.
Exactly, the outermost protective layer. And sometimes it cuts deep down into the dermis, which is the thicker, deeper structural layer where, your nerve endings and blood vessels live.
Oh, wow. So going back to that paper cut on a hinge analogy, a cut that goes deep enough to expose nerve endings in a highly sensitive area sounds awful just on its own.
Truly awful.
But why is a crack in this specific anatomical location so uniquely problematic for a patient? I mean, why is it such a big deal?
Well, it comes down to a brutal combination of mechanical stress and environmental exposure. Think about what this specific piece of tissue goes through. Mechanically, the posterior commissure is subjected to significant stretching during sexual intercourse.
Right, the hinge is opening.
Right. And if there's a fissure there, that stretching literally pulls the wound apart. It rips open the healing edges, which causes a specific type of severe, sharp pain called superficial dyspareunia.
So pain with intimacy right at the entrance.
Yes, and environmentally, look at its location relative to the urethra. It is in the direct downstream path of urine.
Oh, right. And urine is not just water.
Far from it. I mean, urine is salty, contains various metabolic waste products, and it's naturally acidic.
Oh, that sounds so painful.
Yeah, when acidic urine hits a raw, open split in the skin, a place where that protective epidermis is just gone, and the nerve-rich dermis is exposed, it causes an intense, severe burning and stinging sensation.
Which is what doctors call dysuria.
Exactly, dysuria. So the patient is experiencing this profound, searing pain during just basic daily bodily functions, as well as intimacy.
That sounds absolutely agonizing. So, okay, we have a clear picture of what the fissure is, and we know exactly where it's happening. But, well, if tissues in that area are evolutionarily designed to be highly resilient and elastic, why is the skin splitting there in the first place?
Well, this brings us to the underlying condition, the second half of our phrase, lichen sclerosus,
Mhm.
which is often abbreviated as LS in the clinical literature.
Okay, here's where it gets really interesting. When you look at the sources you provided, LS is described as a chronic inflammatory skin disease.
Yes,
And it predominantly affects women, though I read it can affect men and children too, right?
it can, yeah, but mostly women.
Right. But in the female anatomy, it does something visually striking to the tissue. It turns it white, shiny, and incredibly thin. The medical literature repeatedly uses this very specific visual, which is cigarette paper skin.
Yeah, it's a very evocative description because the tissue completely loses its elasticity. It becomes crinkled, incredibly fragile, and hypopigmented.
Hypopigmented meaning it loses its natural color.
Exactly. It turns stark white, and it often appears in a very distinct figure-of-8 pattern.
Wait, what does that look like?
So imagine the top loop of the 8 circling the vulva and the bottom loop circling the perianal area. That is the classic distribution of the disease.
Okay, and this is an autoimmune condition, right? So the body's immune system is essentially misidentifying its own healthy tissue as a threat, attacking it, and causing it to become brittle and thin.
Precisely. The immune system creates intense, localized inflammation, and that inflammation actively breaks down the structural integrity of the skin. The collagen fibers in the dermis become homogenized and stiff.
Oh, so that's why the posterior commissure, an area that absolutely relies on its ability to stretch, suddenly starts fissuring.
Yes, the tissue simply cannot handle the mechanical stress anymore because it has lost all its give.
Yeah.
It just snaps.
But the sources bring up a concept that makes this so much worse than just fragile skin tearing.
Yeah.
There is a specific medical phenomenon at play here called the Koebner response, or Koebnerization.
Yes, the Koebner phenomenon is this fascinating, albeit devastating, quirk of dermatology.
Hmm.
It basically describes a situation where mechanical friction, physical trauma, or damage to the skin actually triggers the underlying systemic skin disease to develop in that exact spot.
Or makes it worse, right?
Yeah, it makes an existing lesion aggressively worse.
Wait, let me make sure I'm wrapping my head around this. So the fissure isn't just a painful byproduct of the thin skin.
No.
Because of this Koebner effect, the physical act of the skin cracking, or even just the minor friction from wiping or urine or wearing tight clothing, is actually an accelerant. Like, the trauma of the split commands the autoimmune disease to attack that exact spot even harder.
You nailed it. The symptom actively exacerbates the cause. The skin becomes fragile from the LS, so it tears. That tear is a physical trauma.
Right.
And that trauma triggers the Koebner response, which summons a massive rush of inflammatory immune cells to the site to, quote-unquote, fix the damage.
But the fix is broken.
Exactly, because the immune response is faulty, that inflammation causes more LS damage. It makes the skin even thinner, stiffer, and more scarred.
Which makes it tear even more easily the next time it's stretched. Wow. It is a closed, self-amplifying loop of destruction.
It really is. It's like the body's natural repair mechanism has been completely hijacked to lay down diseased, brittle tissue instead of healthy tissue.
And this vicious cycle explains why, if left untreated, LS causes profound architectural changes to the human body over time, doesn't it? Because the chronic inflammation and the constant pathological scarring don't just thin the skin, they fuse it together.
Yeah, they do. And the sources mention some pretty severe structural losses if this goes unchecked.
What kind of losses?
Well, the labia minora, the inner lips, they can shrink, flatten out, or completely resorb into the surrounding tissue until they're practically gone.
Resorb, like the body just absorbs them back.
Exactly. And the clitoral hood, which is the skin protecting the clitoris, can scar and seal entirely over.
Right.
This buries the clitoris and can trap smegma underneath, which sometimes forms painful cysts. The physical anatomy literally alters and erases itself in response to this chronic, misdirected immune attack.
Wow. That completely reframes the entire condition. I mean, it's not just a rash that causes a bit of itching or discomfort. It's a progressive disease that will permanently erase and fuse normal anatomy if doctors don't step in to stop that from happening.
You have to intervene to break the autoimmune loop. There's no other way. And you break it by attacking both the mechanical triggers on the outside and the immune response on the inside simultaneously.
Okay, let's start with those mechanical triggers. The first line of defense in the clinical guidelines seems to be the barrier method. The rules for general care are very strict. Patients are told to completely avoid regular soap, bubble baths, fragranced products, or honestly anything that strips the skin. Instead, they use bland emollients, which are heavy medical-grade moisturizers or ointments.
Yeah, think of emollients as a synthetic shield. A normal, healthy epidermis has a lipid barrier that keeps moisture in and irritants out.
But the LS skin doesn't have that anymore?
Exactly. It's lost its natural barrier function. So you have to manually paint one on. An emollient protects that incredibly fragile cigarette paper skin from the acidity of urine, which directly reduces the chemical trauma.
It also provides heavy lubrication, right? Which would reduce the mechanical friction from just walking or wearing clothing.
Spot on. And by aggressively reducing that friction and chemical irritation, you're actively depriving the Koebner response of the physical triggers it needs to accelerate the disease.
So you're turning off the fuel supply.
Yeah.
But you still have the raging fire of the immune system to deal with. And for that, the guidelines bring out the heavy hitter, which is ultra-potent topical corticosteroids, specifically clobetazol, Propiant, 0.05% ointment.
Yeah, clobetazol. This is the gold standard first-line medical treatment.
Yeah.
It is an incredibly strong immune suppressant, and it's applied directly to the affected skin to just completely shut down that faulty inflammatory response.
You know, reading through the clinical regimen for this, it's really like fighting a massive, deep-rooted forest fire.
How so?
Well, you don't just fly over, spray a little water once, and assume the job is done right. You have to douse it heavily at first to kill the visible, raging flames. And then you have to literally stand there and spray the embers for months so the wind doesn't cause it to spontaneously combust again.
That is a perfect analogy. You cannot use an ultra-potent steroid casually. The standard induction regimen detailed in the British Association of Dermatologists guidelines, it operates on a very precise 3-month tapering schedule.
So what does that schedule actually look like for the patient on a daily basis?
Well, the patient applies a very specific small amount of the ointment. To give you a sense of scale, a standard 30-gram tube should last the patient 3 to 6 months.
Oh, so a tiny amount.
Yeah, you don't slather it on like sunscreen. You apply a precise, thin film just to the affected areas. So for the first month, they apply it once every single day.
Okay, the heavy dousing of the fire.
Exactly. Suppress the acute roaring inflammation. Then for the second month, they step it down to alternate days, so every other day.
Got it.
And for the third month, they step it down again to just twice weekly.
And after that 3-month induction period, they just stay on that twice-weekly maintenance dose, right?
Yeah.
Potentially for years to keep those embers cool.
Yeah, usually long-term maintenance. And what is remarkable is how effective this specific regimen is when it's adhered to properly. I mean, it doesn't just stop the terrible itching and pain. It halts the scarring process in its tracks.
Which gives the tissue a chance to actually heal those agonizing fissures at the posterior commissure.
Yes. And in many cases, it can actually return the skin texture much closer to normal, largely reversing that thin, crinkled appearance.
And there is a massive long-term benefit mentioned in the guidelines, too. LS carries a small but very real increased risk of developing a type of skin cancer called squamous cell carcinoma, or SCC.
Right.
But sticking to this steroid maintenance regimen significantly lowers that long-term risk.
And this is a crucial point of causality, actually. To understand why it prevents cancer, you have to look at what chronic inflammation actually does.
Okay.
Inflammation is an emergency response. It signals cells to divide rapidly to heal perceived damage. When the immune system is constantly attacking the vulval tissue for years on end, the cellular turnover just goes into overdrive.
Ah, so the cells are copying themselves over and over again, way faster than normal.
Exactly. And every time a cell divides, there is a tiny chance for a copying error, a genetic mutation. So the more the cells are forced to divide, the higher the mathematical probability that one of those copying errors turns into cancer.
Wow, so by applying the topical steroids and suppressing the inflammation, you slow that frantic cellular division back down to a normal rate. You are literally preventing cancer at a cellular level.
It is preventative medicine at its absolute best. However, and there is a however here, topical steroids have their limitations. They are brilliant at halting active disease, healing fissures, and stopping new scars from forming.
But they can't turn back time.
No, they cannot reverse permanent, established anatomical scarring. If the skin is already fused shut, the ointment isn't going to magically unfuse it.
Right, so if a patient went undiagnosed for years and their posterior commissure has torn and healed over and over again, laying down those thick bands of severe scar tissue, the actual entrance to the vagina physically narrows.
Yes, this condition is called introital stenosis.
So what does a doctor do for the patient whose active disease is completely cured? Like their skin isn't inflamed anymore, the cancer risk is managed, the LS is in remission, but they still suffer from intense blockading pain during intimacy simply because the physical opening is now too narrow from all the old scar tissue.
This is where medical management hits a wall, unfortunately, and has to hand the baton to surgical intervention. When ointments aren't enough to restore mechanical function, surgeons utilize a procedure known as Fenton's procedure, or the modified Fenton's.
I was looking at the surgical mechanics of this, and it is a fascinating piece of tissue engineering. It's usually a day case surgery done under local or general anesthetic with one single goal: to widen that tight, scarred ring of tissue at the vaginal introitus.
It is essentially an exercise in applied geometry and tension release.
Yeah.
The surgeon targets the heavily scarred posterior commissure, and they make a longitudinal incision, so a vertical cut straight down over the lower vagina and the perineum. This cuts right through the restrictive, rigid band of scar tissue.
But, I mean, if you just sew a vertical cut back together vertically, you end up with the exact same tight ring you started with. You haven't actually gained any space.
Exactly. So here's the clever part. By making that vertical cut, you release the tension holding the tissue together. The surgeon then gently pulls the edges of the incision apart laterally, opening the wound up into a diamond shape.
Okay, a diamond.
Then they suture it closed transversely, horizontally.
So they pull the top and bottom points of the diamond together, they take a vertical cut and sew it up horizontally. That physically borrows healthy elastic tissue from the depth of the vagina and pulls it outward, immediately increasing the diameter of the opening. It's like biological origami.
It really is. It resolves the mechanical narrowing instantaneously.
Hold on, though. As I'm mapping this out in my head, I'm spotting a massive glaring contradiction based on everything we learned about the immune system earlier.
Oh, let's hear it.
Well, we established that any trauma to the skin, any friction or tearing, triggers the Koebner response and makes lichen sclerosus flare up, right? The
Yeah.
immune system rushes in and creates more brittle scar tissue.
Yeah.
Isn't a surgical scalpel the absolute ultimate trauma? I mean, won't slicing the tissue vertically and sewing it horizontally just ring the dinner bell for the autoimmune disease, causing it to aggressively attack the surgical site and just scar the whole area shut again?
You have just identified the exact reason why surgical interventions in LS patients historically had a notoriously high failure rate.
Seriously?
Yes, a scalpel is massive physical trauma. Left to its own devices, the body will initiate a massive Koebner response. The immune cells will swarm the surgical site, the inflammation will spike, and the incision will scar right back down, often tighter than it was before the surgery.
Wow. So how do you perform the surgery without the surgery ruining itself?
By heavily and proactively suppressing the immune system, the exact moment the tissue starts to knit back together. To prevent the surgical trauma from causing readhesion and Koebnerization, the postoperative management has to be flawless. The patient must resume using the ultra-potent topical steroids roughly 48 hours after the surgery.
Oh, wow. So you don't even wait for the stitches to come out or for it to fully heal normally. You give it just 2 days to seal the rawest edges, and then you start suppressing the immune system immediately.
You apply the clobetasol directly to the healing surgical site. This effectively blinds the immune system. It stops the Koebner response from firing. The steroid ensures that the body heals the surgical wound like a normal, healthy wound, rather than an LS wound.
That is wild. And the sources also mention the use of vaginal dilators postoperatively, right?
Yes, very important. While the tissue is healing in its new horizontal orientation, the patient uses graded, smooth cylinders called dilators. This gently maintains the new width of the introitus and prevents the healing tissue from shrinking inward as it contracts.
So it's a dual approach?
Exactly. The combination of the physical dilator keeping the space mechanically open and the chemical steroid keeping the inflammatory scar tissue at bay allows the newly widened area to heal properly without triggering that devastating autoimmune relapse.
It is a total high-wire act of managing the body's natural responses. You have to physically cut the tissue to fix it, but then you have to chemically trick the immune system into ignoring the fact that you cut it.
It requires immense compliance from the patient and perfect timing from the physician. But when executed correctly, it restores anatomical function and completely eliminates the mechanical pain that was trapping them. It gives a patient their quality of life back.
That is just incredible. Okay, let's take a breath and recap this journey because you sent us down a fascinating path today. We started by mapping out the anatomy, right? Defining the posterior commissure as that vital dynamic hinge at the back of the vulva.
Right.
And we learned what a fissure is and why that specific spot makes a skin split so uniquely agonizing due to constant stretching and the acidity of urine.
And we then explore the root cause, lichen sclerosus, and how it structurally thins the tissue. We unpack the Kubner response,
Yeah.
that paradox, where the physical trauma of a fissure actually accelerates the underlying autoimmune disease.
Which summons inflammatory cells that lead to severe architectural fusion if left untreated.
Exactly.
Then, to break that vicious cycle, we looked at the precise forest fire tapering regimen of ultra-potent topical steroids. We learned how shutting down that constant cellular division not only heals the skin, but literally stops genetic mutations that lead to cancer.
Yes, highly preventative.
And finally, for permanent scarring, we explored the clever geometric origami of Fenton's procedure and the absolute necessity of using steroids immediately after surgery to outsmart the body's own immune system.
It highlights how managing complex vulval dermatosis really requires treating the mechanics and the immune system at the exact same time.
Which leaves us with a final thought for you to ponder. If doctors can successfully use topical steroids to chemically blind the immune system during Fenton's procedure, basically tricking the body into healing a major surgical wound without laying down massive amounts of restrictive scar tissue, what does that mean for the future of surgery as a whole?
It's a great question.
Imagine if we could adapt that exact same protocol of highly localized, perfectly timed immune suppression for open heart surgery or, joint replacements, where internal scar tissue is one of the biggest, most dangerous complications. The ability to negotiate with our own biology in that way could revolutionize how we heal from trauma.
It really suggests the key to perfect surgical recovery may not just be in how we cut the tissue, but in how we manipulate the immune system's memory of the cut.
It's a fascinating frontier. Thank you for sharing these sources with us and sending us on this deep dive. Keep exploring, keep questioning the world around you, and remember that even the most clinical-sounding jargon usually hides a profound story about how we put ourselves back together. We'll see you next time.